Hello, I'm Dr. Marla Shapiro. One of the most common issues yet not talked about is sexual health. And today joining me to talk about sexual health is Dr. Sheryl Kingsberg. Welcome, Sheryl.
Thank you for having me.
Sheryl is a clinical psychologist and chief of the Division of Behavioral Medicine in the Department of OB-GYN at McDonald Women's Hospital, University Hospital Case Medical Center, and she's also a professor in the Department of Reproductive Biology and Psychiatry at Case Western Reserve University. So what is common that women are not talking about?
Sexual problems are common, and they really aren't talking about it, not to their friends, not to their partners, and certainly not to their healthcare providers. And that's really a shame. There are so many common problems. Women think they're alone, but the two most common sexual problems that affects millions of peri- and postmenopausal women is loss of desire and pain with sexual activity that is the result of menopause and a decrease in estrogen in the vagina.
So one of the important messages is, I think, if your physician isn't asking, that doesn't mean you shouldn't be saying.
Yes, unfortunately, if you think about physicians and other healthcare providers, sometimes they're a little nerdy and they're not all that comfortable talking about sex. That's okay. We are teaching them that it is absolutely appropriate, that they need to manage your health care because sexual health is a basic human right, and that's your right. So if your healthcare provider is not asking about it, then you ask about it, and if they're uncomfortable, you get another healthcare provider because this is something really important to your basic health and to your quality of life. And we now can treat many of these sexual problems.
So let's first talk about vulvovaginal atrophy, that VVA that women hear about.
Sure.
Basically having pain with sexual intercourse. Where does that come from, and is it going to get better on its own?
Well, vulvovaginal atrophy, which we now call genitourinary syndrome of menopause because nobody likes to think about themselves as having atrophy, but it is related to menopause and the change in estrogen levels. As your estrogen declines, it actually affects the tissue in your vagina. And without treating that, unlike hot flashes, which I know it feels like they'll last forever, but they eventually go away, vulvovaginal atrophy and the changes in your vaginal tissue do not get better. It doesn't go away, and in fact gets progressively worse.
So many women have gotten the message that they don't want to take estrogen, they hear estrogen and they physically recoil. What messaging can we tell women about local estrogen or some of the newer oral medications to treat painful intercourse because of a dry vagina,
Sure.
if you will? What can we tell them?
Well, I think there is a misperception that local estrogen is the same as systemic estrogen. And the fact is that local estrogen really is local. That is, it is inserted into the vagina and does not get systemically absorbed into the bloodstream. A wise physician, I think her name was Dr. Shapiro, explained to me that if you can equate the amount of estrogen in, for example, 1 year's worth of using Vagifem.
1 year, so a vaginal ovule.
Yes, that is the equivalent to one birth control pill.
An important difference.
It is.
To understand the dosing.
Even I can do the math on that one.
Okay.
So it is not systemically absorbed. So the risks, although the package insert would suggest that the risks are the same, it is not. So many women can safely use local estrogens without worrying about systemic absorption.
And the new oral medication that's available?
And we also have Asthena that is now available, which is not technically an estrogen, it's a SERM, a selective estrogen reuptake modulator, is taken orally, but it also works very locally. And that also helps with the changes in the vaginal tissue to restore it back to its premenopausal state.
Okay, so now let's talk about desire.
Okay.
And what is out there to treat desire, because up until now, women really have had not a lot of options.
Well, desire is actually the most prevalent, or loss of desire is the most prevalent sexual problem across all age groups, but particularly in postmenopausal women. And I'm not talking about, intermittent loss of interest or being stressed or being mad at your partner. This is a persistent loss of at least 6 months, but most of you who are suffering from loss of desire would know that it's been there for many years. Despite having a good quality relationship, women will come in and they'll say, I have lost the wanting to want. Okay, you can have oftentimes arousal and orgasm. You can still go through having a sexual response that's okay, but what's missing is the wanting, the anticipation, or the feeling of reward that comes. And up until this year, we have had no pharmacologic options. You've only had psychotherapy or couples therapy to address sort of the motivation or the underlying psychological factors that might contribute to loss of desire. But for many women, those are not the factors. There is a biologic change. Desire is actually in the brain. That's our most important sex organ. And there's an imbalance in neurochemistry, not all that dissimilar to how we understand the biology of desire.
So what's available now?
So now we have ADDY, ADDYI, which is the first FDA-approved pharmacologic option. It is a central nervous system drug.
Flibanserin, for those who've
Yes.
heard that in the media.
Right. Flibanserin is the generic name, and ADDY is the brand name. And it is a non-hormonal treatment that works on the brain chemistry to essentially rebalance, to allow the ability to keep your attention focused and to address the dopamine receptors that increases our ability to experience reward and motivation.
So bottom line for the women who are listening is that they have to advocate.
Yes, I think use your language. Talk to your healthcare provider. Ask about treatments, because you're not alone. This is very common, and it is really up to your healthcare provider to help you with your sexual concerns. That's the place to go.
Thank you so much, Sheryl.
Thank you.